grand rounds. And, for me, this morning is really a very special treat in that I get to, introduce a former colleague and, very good friend, Joseph Zabner, to, grand rounds. Joseph is the director of the Division of Pulmonary Critical Care and Occupational Medicine at the University of Iowa, where he's also the Sturba Professor of Internal Medicine. Joseph's medical career began in Venezuela, where he got his MD degree, and then he completed residency at UT Southwestern, and then moved to Iowa, for fellowship in 1991. And he and his wife, fell in love with the rolling hills of eastern Iowa, the Iowa Hawkeyes, and nice, crisp, wintry days. And and Joseph, really, has had an amazing career at Iowa. He's a absolutely incredible physician, scientist, national leader, outstanding mentor, a great division chief. And he's really garnered incredible national acclaim for his work, in the area of cystic fibrosis. And, his work initially focused on, gene therapy for cystic fibrosis and identification of, viral vectors. And along the way, his research really elucidated important aspects of the pathogenesis of cystic fibrosis, the testing of, potential, novel gene therapies, as well as the role of airway epithelium in the pathogenesis of cystic fibrosis and the development of therapies to protect airway epithelium, prevent infection. He's the author of over 200 articles, and when you review his CV, it's absolutely amazing, the caliber of his papers, including, many in Science, Nature, Cell, the Journal of Clinical Investigation, and a number of other top journals. He's had virtually continuous funding from the NIH since he arrived at Iowa. He's also, been funded from the Cystic Fibrosis Foundation and a number of other entities. In addition to his own research and directing a program project in cystic fibrosis, he's the director of a T32 program, a training program that's really been phenomenally successful in, training a number of, really top-notch junior investigators. He has received a lot of national acclaim. He's an elected member of the American Society of Clinical Investigation, the Association of American Physicians, and the American Clinical and Climatological Association. And he's also, I think, an incredibly creative, scientist, and I think his research also highlights the potential promise of translational medicine in his ability to take discoveries that he's made in the lab, apply those to develop novel animal models, and then novel therapies that, have entered clinical trials. So it's a real privilege to be able to, pleasure to introduce Joseph this morning. His talk will focus on aspects of the pathogenesis of cystic fibrosis and sort of the implications for personalized medicine. In addition, he's going to, at the end, provide his insights on who's going to win the Iowa caucus. So please join me in welcoming Joseph.
Thank you, Gary. It's a pleasure to come here. First, Gary was a department chair at Iowa while I was a division director, and I learned a lot from Gary. His organizational skills, his vision at the CTSA, his ability to work in teams and create teams is amazing, and you're lucky to be here. I'm also thankful Carl, who we worked together for several years, and it's been a role model on what a master clinician should be. I'll do it here. So I don't have any conflict of interest. And the take-home points of this talk is that there are many diseases that present as bronchiectasis. Cystic fibrosis is one of the diseases, and it's caused by mutation CFTR. Mutation CFTR disrupts function in different ways. If you look at mutation-specific therapies, you can find miracle drugs. And I'll tell you a Spanish joke that says, no es lo mismo. And the learning objectives as to how to diagnose bronchiectasis, what's a differential diagnosis, and new therapies for cystic fibrosis. So I truly believe that lack of knowledge about disease pathogenesis has been the major hindrance for identifying new therapies. So in Pulmonary, we have been for years trying to find therapies for COPD, for IPF, for asthma, and we have had marginal improvements in the treatments of these diseases. And in part it's because these are not diseases. These are syndromes that contain many, many different diseases. And as an example, COPD, one of the diseases that can present as COPD is bronchiectasis. Probably similar things happen in IPF and asthma. And if you can break these diseases into the individual diseases, you are more likely to find good therapies. So bronchiectasis is a disease that when I went to did medicine in Pulmonary, we just kind of didn't care about because there were no therapies. We diagnosed it, we would see patients who come into the clinic coughing, purulent sputum. They usually had a lot of weight loss. They complain of having intermittent hemoptysis, and their PFTs showed low FEV1 and low DLCO, so they were categorized as having COPD and be treated with beta agonist and without improvement. So to make a diagnosis, they got a lot better once we had high resolution CT scans. When I went to medical school, they told us that the chest X-ray showed signet rings and tram tracks, and to be honest, I didn't understand what those words meant. And so I changed the name to engagement ring and railroad tracks. So the normal bronchus is very, very thin in the small airways, and you cannot see it on an X-ray. If this airway becomes dilated and the walls are edematous, then you'll be able to see one of the walls of the airways air in the middle, and another wall of the airway, and it appear to be a railroad tracks. And here you can see, these railroad tracks in an X-ray. If you look at a CT scan, then you can even see these better. Here you can see, railroad tracks, and also you can see the engagement rings, in which the distal airways should be smaller than the vessel, artery that goes next to it, and should be so small that you rarely can see it. But if it gets dilated, all of a sudden you see these things that look like an engagement ring. You see the airway with the artery next to it looking like a diamond. So the classic classification that I learned in medical school that was based on the appearance of this bronchiectasis on a bronchogram. And they were not very helpful. At the end, there was no treatment, and we did this really difficult test for nothing. So the differential diagnosis over the last 20 years has increased, where now we know 50 different diseases that can cause bronchiectasis, and most of them, we know them at the molecular and genetic level. So the one that I'm interested in, I'm going to be talking today about is cystic fibrosis. The second one that we have discovered a lot is dyskinetic cilia syndrome, where mutations in any of these components of the cilium result in either cilia that don't move or they move in a discoordinated way. And there are 50 different genetic diseases that cause dyskinetic cilia syndrome. Some of them, they also affect the primary cilia and result in the heart and organs being in the wrong side, and that's called cartilaginous. Tuberculosis is the most common cause of bronchiectasis in the world, and then other ones that are less common: allergic bronchopulmonary aspergillosis, immunodeficiencies, post-infection, emphysema, pulmonary fibrosis. So I'm going to start with the case report. This is a 23-year-old female who had been complaining of sinus infections and cough for a long time. She had the recurrent sinus infections, the antibiotics for every second or third month, had been coughing up all her life and intermittent sputum production, and had increasing dyspnea and occasional wheezing. Review of other systems, had a history of constipation and was very thin. Her weight was 49 kilograms, which is a BMI of 18, which is low, and had crackles on the right base. When we got a CT scan on her, a pulmonary function test showed that she had an FEV1 of 2.5 liters that would qualify her as COPD. We got a CT scan on her, and we found that she had really, beautiful engagement rings, and really dilated airways that in this case look like a railroad track. So we considered the possibility that she might have CF, and again, one of the things I want to point out that we are diagnosing 2 to 3 cases of cystic fibrosis in adults at Iowa, and it's something that should be in your differential diagnosis. Not all CF patients are diagnosed by pediatricians. Her sweat chloride test was 85 and 93, and the normal is less than 60. So just by having this history and a sweat chloride test of 85 makes the diagnosis of cystic fibrosis. We also obtained a nasal voltage that showed that she had a very high voltage in the nose, and I'll explain that later. And when we challenged the epithelia of the nose by removing the chloride from the perfusate of the nose and putting isoproterenol, there was no change, again suggesting that CFTR was not functional. And we sent a genetic analysis for CFTR mutations, and those will come back in a few weeks. She was admitted to our pulmonary ward for IV antibiotics, airway clearance, chest PT, bronchodilators, DNAs, hypertonic saline, exercise, nutrition, GI, endocrine workup, which is a standard therapy for CF. And again, at that point, it was very, very devastating to tell a young person that she had a disease that had no treatment. Cystic fibrosis was elucidated in 1989 when Francis Collins figured out that it was caused by a mutation in a gene called cystic fibrosis transmembrane regulator. And in 1990, Dr. Walsh at Iowa found out that this gene encodes for a channel that is a chloride and bicarbonate channel that allows bicarbonate to go out of the cell and chloride to go in or out of the cell. It conducts, and it's present in all epithelia. Because it's present in all epithelia, malfunction of this channel results in malfunction of many different organs that have epithelia in them. Include airways, which is what we are more interested in because it's the most common cause of morbidity and mortality. The liver, it causes plugging of the small bile ducts and eventually cirrhosis. Pancreas, some of the patients end up having pancreatic insufficiency and destruction of the pancreas. Bowel, it's not uncommon for newborns to have meconium ileus and for adults to have a DIOS, which is distal intestinal obstruction syndrome. In men, the vas deferens has an epithelia that is similar to the airways, and they develop congenital bilateral absence of vas deferens. And in sweat gland, you end up with salty sweat. So again, the airway and the sinuses are the most common morbidity and mortality for these patients. CF is a different disease now because of everything we have done just to improve the symptoms of the patients. In 1949, the description of the cystic fibrosis used to be it's called like that because the pathologists found that the pancreas had cystic fibrotic lesions. And a lot of the name stuck on, it's not cystic fibrosis of the lung, but of the pancreas. And in 1949, when Dorothy Anderson describes this disease, the paper showed that it usually fatal in infancy or early childhood. So she was a pathologist and was reviewing the autopsy of little children that had died with meconium and found this disease. In 2020, we have adults in clinic, and it's a completely different disease. More than 50% of people who are living with CF right now are adults. So this is moved from being a pediatric disease to an adult disease. In 1986, a third of the patients were adults, and over the last 20 years or 30 years, we've gone up to 55% of the patients in the country with cystic fibrosis are adults, and that's explained by the fact that the people are living longer. These people with adults with CF are not are functional people. I'm going to show some data in a few slides of an engineer at the University of Iowa who has participated in all the clinical trials I've done, and you could not tell, that he had CF. When we walk together and we have played golf together, people think I'm sick and he's healthy. Now we have tripled the number of people who with CF who get married. A lot of women and men have children. A lot of them go to school. We have quadrupled the number of people who go to college. And at the University of Iowa, I started the adult CF center program with one patient when I finished my fellowship, and now we've gone to having 128 patients. And our director of the CF center is Doug Hornick, who is a true master clinician, and also he's the director of our therapeutic development network. So this multiple of people taking care of these patients has resulted in improvement in their survival and their performance. But still, we needed to find a treatment that would ensure that it would be healthy. Moreover, the fact that these patients are living longer has made it very important for internists, not only pulmonologists, to know about cystic fibrosis. Endocrine, a lot of the patients with CF develop diabetes, and some of them develop insulin-dependent diabetes because as they live longer, the pancreas continues to be destroyed and they lose their beta cells. Intestinal obstruction, the gastroenterologists have to deal with that, and the pancreas, they have pancreatic insufficiency and they need to take pancreatic enzymes. Immunology, they have to be desensitized because they have multiple need for antibiotics, sometimes very specific antibiotics based on the sensitivities of the bacteria. The ID, we need them to treat resistant organisms, and a lot of the patients with CF develop non-tuberculous mycobacterium that also needs to be treated. A lot of our patients develop pulmonary hypertension. Some of them are starting to get coronary artery disease. They need to get health maintenance. I remember the first time I sent a patient to get a colonoscopy. Renal, the aminoglycoside toxicity is a huge problem, and a lot of the patients end up developing renal failure. They get malignancies, and there is some malignancies that are at increased risk, for example, colon cancer. Geriatrician, they need to deal with the osteoporosis that these patients have. A lot of them, when they were younger, were treated with steroids, and they have a real big problem with osteoporosis. And the urologists have to deal with the congenital bilateral absence of vas deferens. So I'm continuing with our case. Our young lady that we diagnosed with cystic fibrosis, we have had her genotype come back, And he came back with a mutation, a very rare mutation, P205S, and the second most common mutation in CF, which is G551D. Again, we had treated her, she gained some weight, she looked a little bit better, but now we have a diagnosis that she has CF due to these mutations. So I'm going to extend back to some basic science. Right after the gene for CF was discovered, Mike Walsh showed that it was a chloride channel, and then over the next 3 years, he and his team in the lab went on and characterized several mutations in CF that cause cystic fibrosis, and they categorized these mutations in 4 different groups. So the first group is class 1. It's mutations in which there is a stop codon and the protein doesn't get made. So there is no CFTR, and that's why you don't get chloride transport. An example of this is W1282X, which is a very common mutation in Ashkenazi Jews. The second one is the class 2 defective processing. So the protein is made, is complete, but there is a conformational change that prevents it from going into the ER, out of the ER into the Golgi, and gets stuck in the ER. An example of that is Delta 508, which represents 70% of people with CF. The third one is a defective regulation. So the channel is you can think of a channel of a door that keeps opening and closing. And people who have this mutation, the protein makes it to the Golgi, makes it to the cell membrane, but it doesn't open enough. And an example of that is G551D. That's a mutation that our patient had. And finally, there is a defective conduction. The door opens and closes appropriately, but doesn't open big enough. And so less chloride can go out. And out of the 1,000 mutations that have been identified over the last 25 years, most of them fall in one of these 4 categories. So I'll talk a little bit about the G551D, the mutation that our patient had. 4 to 5% of people, Caucasians, have this mutation. And the Cystic Fibrosis Foundation decided to collaborate with a company in San Diego called Aurora Biosciences to have them develop a medicine that will, a small molecule that will correct this defect in getting the door open and close. The CF Foundation had funded a lot of investigators over the country, so a collective knowledge of many, many physician scientists went into helping Aurora Biosciences design this screen. And the screen was done by getting some cells that were developed in Iowa, fish or rat thyroid cells, and these cells don't have any channels. So the cells were engineered in Iowa to express CFTR. A wild-type cell would have a wild-type CFTR, and the G551D cell would have CFTR that didn't open and close normally. In these cells, there was a fluorophore that would be quenched if there was a lot of iodide in the cell. And a fluorophore is a protein that is related to green fluorescent protein that is seen in jellyfish, and this fluorophore had been engineered to not be fluorescent when there's a lot of iodide in the cell. They tested hundreds of thousands of compounds to see if any of these compounds could open CFTR. So if one of these compounds would open CFTR, then iodide could leave the cell. And if the iodine concentration inside of the cell will go down, then it would become fluorescent, and you could detect that as a hit of a compound that was opening CFTR. So I learned from working with him, getting hits was not difficult. The difficult part was to get hits that were right, that was doing things through CFTR, that had the right characteristics for pharmacokinetics that could be produced, and they kept going over and over again, optimizing the the hits until they got a few that they thought were promising. So they asked me to perform a secondary screening. And at Iowa, every time somebody with CF gets a lung transplant, we get their lungs, and we isolate the airway cells, and we can freeze them, and we can use them to grow them at the air-liquor interface. So once they grow at the air-liquor interface, they look like a small trachea on a filter. So they sent us a few of these compounds. We studied them for electrophysiology. And this is an example of one of these compounds that tested on a patient's cells that had G551D. So you can measure a current that is a chloride current. You put a amiloride, the current goes down, and then when you activate CFTR, there is no current because there is no CFTR. However, when we tested this medicine, we could take these same cells to develop a current that was identical to what you would see in somebody who didn't have CF. So that was a really exciting day in the lab because I had collaborated with many companies to do these secondary screens, and even though I thought it was important, it was getting old because nothing worked. All of a sudden, something worked. And then the Cystic Fibrosis Foundation got the Therapeutic Development Network to test these on people. And we were fortunate to be the first site to test one of these patients. And we did this on my friend who's an engineer at the University of Iowa. So in order to test this in vivo, we can measure the voltage in the nose. The nasal epithelia looks very similar to the trachea. And again, if we remove the chloride out of the fluid in the nose, chloride would tend to go out and change the voltage. This is what a normal person would look like. They have a voltage. You remove the chloride and activate it with isopropanol, and the voltage goes up. And in a CF patient, you see nothing. And when we took measured the voltage of a Dusty on the first day before the treatment, we removed chloride and put isopropanol, and nothing happened. And 15 days later, the voltage went up. And again, this is really exciting because I had measured his voltage maybe 50 times, and all of a sudden his voltage looked like normal. So very, very rapidly, this medicine was tested on phase 1, phase 2, phase 3 trials, and resulted in a medicine that it's really a miracle drug. And it got approved by the FDA within 2 years of the first experiments being done. I'll show you, what a real drug looks like. This is a paper was published by Bonnie Ramsey in 2011. The sweat chloride that our patient had 86, in all these patients that received placebo was around 100. This is very, very abnormal. There are standard deviations there. You can barely see them. Once they were treated with Ivacaftor, within 15 days, and actually in subsequent studies, you can see that 2 days after you start treating him, the sweat chloride becomes normal. It's and again, there is no. Some people did, some people didn't. Everybody became normal, and there is no standard deviations there. When we look at a pulmonary function test with a placebo, the pulmonary function test went down within 48 weeks. And Ivacaftor, it went up as soon as 15 days. And again, studies that were done by us is shown that they go up within 2 days. So this is a medicine that for this small group of people, this is 800 people in the United States, can completely change their life. They had fewer pulmonary exacerbations, improved respiratory symptoms, and this is really, really amazing. David Stoltz developed a methodology to look at air trapping using Vida Diagnostics. This is one of these patients. The bigger the circles in the CT scan, the more air trapping there is. And after 2 days of being on Ivacaftor, these big areas of air trapping become a lot smaller, and areas that have some air trapping are completely normal now. This is our patient. She had really bad sinusitis. These are the ethmoid sinuses and the maxillary sinuses, full of mucus. And 10 months after starting Ivacaftor, they became normal. This is a CT scan, before getting started on Ivacaftor. And again, here you see a lot of mucus plugging. You don't see the engagement rings because the airways are full of mucus. And here you see a railroad track. And 400 days after the starting on therapy, the mucus plugging is gone, the railroad tracks are gone. There is a marked improvement in bronchiectasis. I truly thought that would be irreversible, but we're seeing that a lot of the bronchiectasis is reversible. There is also CFTR activity in other organs, and we saw things that were surprising. So one of the most surprising ones is that within weeks, these patients gain a lot of weight. And again, weight loss is a huge problem in patients with CF, and it's not all completely related to the lung infection. And on average, they gain 3.5 kilograms. The intestinal pH, after gastric emptying, in normal people, you secrete bicarbonate through the pancreas. CF, they don't, and people who are on Ivacaftor started secreting bicarbonate in the pancreas. And insulin secretion, which is also a problem, got better. So now once the FDA approved this drug, now there is a miracle drug for class 3 mutations, the example is G551D. Within a few years, we've realized that other mutations could be treated with the same medicine, including the class 4 mutations. And then Vertex developed a medicine for class 2 mutations that combined a corrector, something that helped the protein make it out of the ER, and also combining it with a potentiator that will help it be open more. That medicine was not a miracle drug. It was statistically significant, but not really that impressive. So they came up with a second medicine, that again was not impressive. But having 5% of the patients seeing what really works, makes you push the clinicians and the companies to develop something that will be better. And in 2019, in December, they got approved the Trikafta, which is 3 drugs in one pill that works identically to the Ivacaftor and G551D patients. So I was going to show the data, but it looks identical. The circulates become normal. So what about the other class, the class 1? The class 1 has no treatment. There is no protein. You can't have a modulator increase the processing, and you can't have a potentiator keep the door open if the protein is not there. So the only option for these patients is going to be gene therapy. And now with new technology, gene editing, where you just change the mutations and try to correct the gene. Also, once you get the gene therapy or gene editing to work, it could be a cure for all the patients where and not have to take a medicine the rest of their life, but just be treated once. So 25 years ago when I went to Iowa, that's what I was interested in. And the question back then was, how can we get a vector to transfer cDNA of CFTR into airway epithelia? And there were 2 camps back then. One camp said we can use cationic lipids. You may have heard this called lipofectamine. And we can develop chemically a vector that could take DNA into the cells. The other camp thought we should use viruses. Viruses have thousands of years of evolution where they have evolved to infect the lungs. So an engineer or a biologist is not going to outsmart a virus. And Dr. Welsh was my mentor. And he asked me to work on the cationic lipids. And I decided I was going to work on both, so I started working on lipids and viruses. And 25 years of work on these. 3 of these ideas, we took it all the way down to clinical trials, putting it on the nose of people with CF. And we got, a signal. We were excited, but nothing that was good enough. And ultimately, what I discovered was these viruses were not good at infecting the airways. We call them respiratory viruses. People use masks to make sure they don't get a respiratory virus. But the viruses don't infect the airways very well. And then I became aware of something called the basic reproductive number. And I decided that maybe the viruses have evolved not to be very infectious, but to the opposite, to be not infectious. And I'll give you what I thought could have happened. So right now, if somebody comes in from China and sneezes in this room, you'll all be very scared that you're going to get coronavirus. And then you could go back to the future. This was different, 10,000 years ago. When somebody came into a cave where 30, 40 people lived in a community and sneezed on them, if this virus was very infectious, then everybody in this cave would have gotten infected and die, and the virus would die too. If the virus was not very lethal, then everybody would get infected and get immunized, and then there was nobody to propagate the virus. So the viruses have not had a pressure to be very infectious. They have had a pressure to be not very infectious, so that one person gets infected, or 2, and then they infect 2 others, and then somebody goes to another different group of people and transmit it to a different place. And that hypothesis is actually validated by the data. The basic respiratory number is the number of secondary cases which one case would produce in a completely susceptible population. If somebody came here from China now with coronavirus and sneeze and spend the whole week at Wake Forest, you would think that a lot of people get infected. The same thing happened when people came from Spain with the influenza 1918 pandemic, or when there was an Ebola outbreak in 2014. So epidemiologists can calculate how many people got infected from each case, and the number is actually very, very low. For the influenza pandemic is 2 to 3 patients per index case. For Ebola, it's 3 patients. And I was looking, on my way here for coronavirus. The number is so low that they can't calculate it. They're not very infectious. So going back to maybe we have had this wrong, where we are not smart enough to design gene therapy vectors. Viruses have evolved not to be very infectious. Maybe we can use evolution to select an infectious virus in a laboratory that will be very, very infectious and use it to treat people with CF. So in collaboration with David Schaefer, we came up with a library of viruses. This is a virus called adeno-associated virus, and it's a tiny virus that doesn't replicate on its own. It needs a co-infection with an adenovirus to be replicate. So we made a library of these viruses by putting 2 different serotypes together and mutagenizing it so that every capsid would have a different protein. So we took made these viruses, took these library of viruses and infected human airway epithelia from the apical side with a very large dose, waited for 24 hours, infected it through the basal side with an adenovirus to amplify the viruses that were able to infect the airways, isolated DNA, and went back, made new viruses, and then repeated this process every time, putting less virus and less time to try to evolve or select a virus that was efficient at infecting human airway epithelia. So after doing this on 15 different human lung epithelia, we came up with one solution. From 10 to the 8 different viruses, one was the best. And the virus was we called it AAV 2.5T. It's a chimera. Half of the virus is serotype 2, the other half is serotype 5, and has one mutation, A to T mutation. So it was pretty amazing to just by doing that to come up with a virus that would be better. We took this wild-type virus and modified it so that would make a green fluorescent protein. And also modified it to make CFTR, and I'm showing examples of CFTR. So we took human airway epithelia, and here you can see the airway epithelia from the top, and here from the side. Each one of these blue circles is a nuclei. It's stained with a dye that makes them blue. Each one of these dots is ZO1, is the proteins that keep the airway cells together on the top of the epithelia. And in green, you can see CFTR. I'm sorry, you cannot see CFTR because this is a CF patient and doesn't have CFTR. So we infected the CF patient with a virus that expresses CFTR, and within 2 weeks, most of the cells express CFTR. You can see CFTR here on the apical membrane, and it's green. So this virus was 500 times better than any virus that we have ever tested in the lab. So I was really excited when we had this discovery, and I was ready to test this again in people. But before doing that, we developed in Iowa an animal model of CF that develops lung disease. It's a pig that doesn't have CFTR. So I thought, well, it's updating. So we took this pig that doesn't have CFTR and infected it with the AAV 2.5T. We were really excited to see what would happen. And not a single cell got infected. And so we repeated the experiment multiple times. We checked the virus. We checked it again on human CF. And finally, we realized that we had rediscovered it happens in every year. We discovered the fact that a virus that evolves in an animal species doesn't infect other species. So now we have a virus that infects human epithelia really well. We have an animal model that it's a relevant model, but this virus doesn't work on that. So we went back to the drawing board and developed a method to evolve a virus to infect pigs. And in the pigs, it was really cool because we can do it in vivo. So we came up with a library, infected 7 pigs in a row, and eventually we came up with a different solution. It was a AAV2H22. It's an AAV2 virus with 5 different mutations. Will somebody sign up?
Back in the day, I used to figure out a bunch of jokes to tell, but it's kind of...
Dr. Rosenthal knows, none of you want to hear my jokes.
Your opportunity, though. That's
right. Princess Meghan, she moved to Canada, left England, and everything started when she had the baby last year. And they called the royal family to tell them that she was in labor. And the royal family said, what's labor? So we have these pigs. They develop CF, we took airway epithelia from these pigs. Again, this is CF pig. You see the nuclei, you see the adherent junctions of the cells, and you don't see any green because there is no CFTR. These pigs don't make CFTR. And then we infected with AV 2.5T CFTR, and nothing happened. So this virus doesn't work at all. So again, we discover that it's rarely that a virus that works on a species works on another species. So we went back to doing this on pigs and came up with a virus called AV2H22. And we took and one of the amazing things about this is since we evolved this in vivo, when we tried it in vitro, it worked really well. But this is the first time that it worked better in vivo than in vitro. So this is one of these pigs with CF. You know, we can take the trachea of the pig and stain the nuclei. This is in vivo with DAPI. The adherent junctions in green, and CFTR is in red. And again, you don't see red because there is no CFTR. And then when we infected with the virus, every single cell was expressed as CFTR in red. So these pigs also had changes in their bicarbonate and chloride transport and the ability to kill bacteria, and we're very, very excited that these might be promising to treat people with CF. So currently we're in preclinical animal studies to do these experiments, and it brings a little bit of a issue with the FDA because we have to convince the FDA that we have a medicine that is going to work on people, but our experimental data in animals is from a different medicine, but I think the FDA is on board, and it's likely that we're going to start studies this year. So the take-home point is the face of CF is changing. There are more adults with CF than children. CF is caused by mutations in CFTR, and it's a chloride and bicarbonate channel. We know now a lot about the pathophysiology and assays, and we can target treatments based on what we know about these mutations. CF affects nearly every organ, is a multi-system, and or internists should know about CF, not only pulmonologists. Medicines directed at the molecular defects are miracle drugs for classes 2 through 5. And the miracle drug is just because they were treating with a medicine a particular cause of bronchiectasis, which is CF, for a particular mutation or class of mutations. We still need treatments for class 1, and we need cures for all of them. So treating syndromes may result in statistically significant studies. So if you would have taken any of these medicines and you would have treated people with bronchiectasis with these medicines, if you have a large enough N, you probably could have found that these medicines work just because a subgroup of people will be benefit. And if you treat 5,000 people, then it would be large standard deviations, but you would be able to. But if you really want to make a medicine that works, you need to figure out what is the disease you're treating and direct the treatment towards that. And I think this is relevant for asthma, pulmonary fibrosis, COPD, and we're trying to figure that out in the community of pulmonary, and hopefully we'll have cures for all these diseases. So acknowledgements, this is the University of Iowa, and this is an amazing example of how a team can work better than individual parts. We currently have 18 different labs doing research in CF and different aspects of CF. A lot of this work is from my lab, and a lot of it is work from other labs and interactions between our labs. And it works really well because I benefit a lot more from all my colleagues than they benefit from me. But each one of them benefits a lot more from all of us than they help other people. So it's been an amazing place to work. Thank you very much, and that's it.
I think we have time to take a few questions.
Thanks. Good morning. Hey, Victor Ortega. I'm one of the CF physicians here at Wake Forest. Welcome. And, I think your work has been one of the leading, has resulted in some of the leading studies that have really led to this revolution in CF care. I'll tell you, as a provider, this is the most exciting time to conduct clinical trials and to take care of these patients. I mean, we're seeing results that nobody would have dreamed of even 4 years ago. So, no, thank you for coming and for giving that outstanding talk. I think the work that you're doing is so relevant because even though we have these great drugs that have been developed, there's still 5% or more patients who don't have a drug. And even among the 95% for which we have a drug, some people go from 50% FEV1, 50% predicted up to 100%, while others have a very small improvement. So even the drugs that we're developing that are precision need to be more precise. And gene therapy is definitely one of the most exciting upcoming studies or sets of work that needs to be done to advance the field forward. And I'm definitely want to hear your take on what you think about how we could be more precise with the current potentiators and correctors that we have. Because I think here at Wake we do stem cell research and we have organoids where you can test mutations, but there's other ways to do this as well. But I wonder what your take is on the issue of variable responsiveness to the current drugs we have with respect to the potentiators and correctors.
So nobody in Iowa wants to listen to me, and nobody at Vertex wants to listen to me. But when you try these medicines in the lab, there's a dose response. The higher the dose, the better they work. And then the higher the dose, they work less well. So it goes up and then starts going down. And I still don't understand why we're not titrating these drugs on every patient the way we titrate, insulin or so we could follow the sweat chloride test and try to figure out at what dose do you have the optimal effect on the sweat chloride. And some patients may need more of the medicine, and some patients may need less of the medicine. And I think the organoid, I don't understand the organoids because it's just you have an assay that you can do. I don't understand the organoids, but you have an assay you can do on people that clinicians can do. So why would you want to go back and take cells out of a patient, bring it in the lab, and see what happens in the lab when you can do it on people?
Yeah. No, and I think I agree that the dosing is also an issue as well. But potentially, different molecules for different people.
Yeah.
And obviously, the reason why we think about organoids or other systems, I think organoids are being tested in other sites also. And stem cell work is that the mutations, some of them are so, as you know, are so rare that you're not going to have you're not even going to have 5 people to conduct a clinical trial to compare drug and placebo.
But you can do an N of 1 trial. Give them medicine for 2 days and see what happens to the sweat chloride. So that's the part I don't understand about the organoids, because you can do things on the patients.
Yeah, I understand. Yeah, definitely. Thank you.
Going way back to the beginning, I'm wondering how often
people with cystic fibrosis marry people with cystic fibrosis, because there's assortative mating, because they grow up together and maybe they find each other. And do you ever see that, or is that just an illusion?
I don't know anybody who does that. I know it's very common on deaf people.
Yes.
So one of the unfortunate things that we figured out a long time ago, that nasty bacteria that some patients with CF have could be transmitted among them. So there is no more CF camps. There is no. We have a CF conference for families at Iowa every year, and patients are not allowed to come, because you are not allowed to have more than one person with CF in a conference room. But they don't get married. I don't know anybody, but I'll look it up. Thank you.
Joseph, that was really amazing and entertaining as well. I just would be interested in sort of your reflection, on your career and sort of, starting out in your fellowship, working with Mike and doing research on, viral vectors as a, vehicle for, gene therapy, and a lot of the roadblocks, that you hit, and, sort of this balance between persistence in an area, that you think has a lot of potential, versus sort of, knowing when to cut bait, on a particular area and move on. And it seems, that the work with gene therapy and cystic fibrosis is, very analogous to sort of immune therapy in cancer, where there was all this, promise, 20 years ago. Things didn't work, people abandoned it, and now that it's, revolutionizing, treatment of a lot of cancers. Just sort of kind of some of the lessons that you learned.
So the first lesson I learned is when I went to Iowa to do this, because I thought it would be a cool thing to do, and when I reflect on what people would have thought of me, it was really stupid. It was, naive. It was, there was no, I would never do that today. So there's something about young people where you want to encourage them to take risk, because I would never take that risk now. And as a mentor now, whenever somebody comes and tells me they want to do something I don't understand, I say, yeah, do it, please. The second thing is, my mentor in Venezuela, we had a very primitive lab, and he told us that the most important thing is not to cure a disease, but to have fun in discovering things in the lab, and that helped a lot, because I guess if your goal is to find a cure, then you'll be likely be a failure. It's really hard. So you have to be motivated by the discovery process and the research and having fun in the lab, and that has always been really. The third thing is you have to be careful, and Mike Walsh was a good mentor. And there was a lot of hype about this, even the words that were used. I remember my first meeting, one of my first meetings, one of our colleagues from the NIH said, well, CF already has been cured. Let's think what else we're going to be able to do, and those things don't help. It helps people get more money and make companies raise money, but they don't help the field. So every time we did an experiment, we, instead of calling them gene therapy, we called them gene transfer experiments, and because we knew that there was no therapeutic potential. It's just we needed to answer a question in a patient so we can move the field forward. And the last thing is that I think it's important is that a lot of our colleagues, they decided to join forces together, and at the UK they got all the people who were working on gene therapy for CF. They made a consortium and they worked together, and that's a mistake, because what you want is like the evolution. You want diversity of ideas, everybody working on different fields, and somebody will get it right. You cannot pick the best idea in a committee. And yes, if you get everybody together, you probably can work faster, but you're only testing one idea. And so those are my recommendations. Is first, you have to have fun. Second, you have to take risk. Number three is don't follow common sense and the flow, So when I started, not far from UNC, when I started in CF, all the books said that CF was a disease caused by hyperabsorption of sodium, and so and I want to say no, it's not. There's nothing to do with sodium. It was unusual to be in a minority, and it's good to be in a minority because the science will ultimately prevail. And we could have been wrong, but at least there was an opportunity to have a different point of view. Thank you.
Thanks so much.
Sorry, the computer set off on me there.